Good evening. Good evening. Thank you for coming out. I appreciate the turnout. Welcome. I'd like to thank Memorial this evening for their sponsorship of this event. Very nice. Dr. Callahan and Evan Davis, who were just here. Thank you very much. So tonight's topic is on, we're going to talk a little bit about a couple of different things as it pertains to the neck. And I probably want to do a little bit different. If you have any questions, just go ahead and raise your hand while we're talking about it. And I'll just go ahead and address your questions at the time that it pops in your mind. That way you don't forget it. It's probably going to be well served at the time of the talk as well. So that way we don't have a whole bunch of questions at the end. We can just kind of address them as we go along. So please feel free to ask what you have in mind. So I'm going to go ahead and start off. We're going to talk a little bit about cervical disc replacement. I'm going to start with cervical disc disease. It's a very common topic, and it's something that is widely experienced amongst the population. I'm sure most of us in this room either have experienced or know somebody who's experienced either an acute bout of neck pain or maybe even, unfortunately, some chronic neck pain. And so you can see that the lifetime prevalence is about 66%, and a very small percentage, fortunately, do experience disabling type of neck pain. And sometimes that neck pain is associated with pain that will go out into the arms as well. When we talk about radiculopathy, that is referring to a pinched nerve in the neck, so it's pain that will radiate down the extremity, either in the arm if it's the neck, or in the leg if it happens to be the lumbar spine. It's about a 3.5 per 1,000 prevalence with the peak in the sixth decade. So that tends to be the bulk of my patients, usually between 40 and 70 when we're talking about neck and back disorders. What exactly is cervical disc disease? We're doing procedures on the neck precisely because of this entity, cervical degenerative disc disease. And what the disc disease actually is, it's not even really a disease, it's really a normal part of maturation. Just like everything else in the body, things will undergo changes, and the disc happens to be one of them. The disc is the shock absorber between the vertebral bodies. It's a cushion, and most of that cushion effect comes from water, which gives us this viscoelasticity. As we get older, the actual intracellular concentration of the ions changes through a concept known as apoptosis. What that means is that there's a programmed cell death. And so the body kind of knows when it's time to start getting older. So these cells in the disc space called the chondrocytes start to basically die off. That's the programmed cell death. It happens to be genetic. Some of it can be as a result of injury, but a lot of it happens to be genetic. And so once this takes place, then the disc starts to dry out because it changes the concentration on the inside of the disc, so the water no longer is attracted to the inside of the disc. It kind of leaches out. It stiffens up, kind of shrinks down, and so what happens is that this soft gelatinous nucleus pulposus, which is in the middle, is no longer very soft. It now becomes very fibrous. And so under normal circumstances, the disc is kind of a sponge, but as patients get older, we get this weakening of the nucleus. The annulus on the outside is the fibers that go around the disc. They start to bulge back. This is the vertebral body above, and this is the vertebral body below. This is an actual specimen, for example. And so you can see the nerve root sitting right in that tunnel. And so as you start to develop these bone spurs and loss of the disc space height, the nerve canal can subsequently become compromised as well. The bone actually reacts to those stresses as well, and when that happens, the bone reacts by laying down new bone, which is how bone spurs are formed. Bone actually remodels itself in the setting of stress. That's called Wolff's Law. So the more stress on that bone, the more bone actually is kind of deposited in that area. And so that's how the bone spurs actually begin. Just a little historical background for the people interested in history of medicine. These types of descriptions go all the way back to 1838 when Dr. Key described what was known as spondylotic myelopathy, which means pinching of the spinal cord in the neck, by what he described as a spondylotic bar, which obviously is an osteophyte projecting back into the canal. 1926, descriptions of radiculopathy started to surface. And at that time, in the later 20s, early 30s, imaging became available. And so Mixter and his colleague Barr were very famous in terms of describing herniated discs in the lumbar spine. Well, that group also described a problem in the neck as well. And by 1944, Pantopake, which was the first myelographic dye, was introduced. So at that point, they could start to image individuals with myelograms and then run them through an X-ray so they could get an x-ray with a myelogram. Didn't have a CAT scan at the time, obviously, they just had the x-ray. So a lot of information could be gained in the early 40s. So what do I do when a patient comes into my office with complaints of neck pain or perhaps even arm pain? Well, how do we go about a normal assessment? So what's the process? And I just want to break it down for you so that we understand exactly how I evaluate folks for really any kind of problem. The first thing is the history, then we move into the examination. And of course, if we want to do laboratory studies, we can get those, and then imaging studies would be last. So as far as the x-rays are concerned, what we talk about is who has x-ray findings on an x-ray. They come in with an x-ray finding, say, I have arthritis, loss of disc space height. Pretty much everybody by the time they're 40. By the time they're 60, it's nearly 100%. But everybody undergoes changes over time. And we know that most of these changes are actually pretty much a part of normal aging. And so if we actually look at MRIs, plain x-rays, most patients will actually have changes on their MRIs and x-rays by the age of 40. So these are normal changes that take place over time in certain individuals. Who's at risk for this? Well, anybody who, like I mentioned, anybody who has a family history. So if your mom and dad had bad necks or bad backs, there's a pretty good chance that you probably will too, because that's the most important predictor, is your genetic history. But there's other things that you can do to yourself, things like smoking cigarettes. Nicotine is very harmful. It impairs the microcirculation of the disc space. It causes the disc space to kind of dry up more or less rather prematurely. High-risk occupations, people that are sitting down, truck drivers, people that do heavy lifting and so forth. But, you know, it's interesting because these types of things that's probably one of the most important things. These are really not that important in terms of developing that, because it's really more a combination of the genes with everything else that you're doing in your life, more genetic than anything else. There was a twin study that was done, so they looked at MRIs of twins. Interesting, one twin was a taxi driver, the other twin was a construction worker. And they happened to do studies, for example, on a bunch of different twins. And the MRI showed almost exact findings from one twin to the next on all the MRIs, which is an indication that it tended to be more as a result of your genetic inheritance as opposed to what you actually do in your life or as lifestyle. But I would discourage people from smoking because that's really not very good for your body in general, but certainly not your disc spaces. Other things like vibrational exposure, maybe trauma, and some other things like previous lumbar surgery, or cervical surgery, I'm sorry. So here's the anatomy. You're looking at the neck from the side, you're looking at the neck from the front, and then this is a cross-sectional view, so you're looking down on top of the neck. 7 cervical vertebral bodies. We can see that C1, the occiput on top of C1 gives us 50% of our flexion extension, and then the C1, C2 joint gives us 50% of our rotation. All of the rest of the motion comes from what we call the subaxial spine, which means below the axis. The axis is C2. So 50% of your flexion extension and rotation comes from below C2. This is the spinal canal right in the middle, and that's the vertebral body. So you can see anything that takes place in the vertebral body, if it pushes back, it's going to push into the spinal cord. The nerve roots come out in this particular area right through here, so if you have a spur that projects over here, the nerve root will get compressed in that area as well. So as I mentioned, the first thing I like to do is obtain a history in the patient. So we talk about, number one, where is the pain? That's important. Is it kind of axial in the neck, or is it radiating down into the shoulder, or perhaps between the shoulder blades? A lot of times people have pain kind of right next to the scapula or shoulder blade. Sometimes it radiates out in the shoulder. Sometimes it goes out into the arm. What's the quality of the pain? Is it sharp? Is it dull? Is it a shooting pain? Is it kind of a lancinating pain? Is it a burning pain? So these types of presentations can sometimes help me decipher what exactly is causing the problem. Is it just kind of a dull ache in the middle of the neck? Because sometimes that's consistent with arthritis. But there's other things too, like tumors or infections, things like that that can actually present as well. How long has the pain been there? Did it just start up yesterday? Or has it been there for 3 months? So those are very important questions to know the answer to. And then, of course, I like to find out some things that pertain to the neurologic status of the patient. Are they having difficulty walking? Are they clumsy? Do they have the so-called numb and clumsy syndrome where the hands are numb and they feel a little uncoordinated when they're walking? because that may indicate pressure on top of the spinal cord. Weakness and numbness, and of course, as I mentioned, fevers and chills and weight loss, perhaps infection or tumor should be considered in that setting as well. The examination really starts off with the cervical range of motion, so I inspect the patient, see if they're listed off one side or the other. Are they perfectly straight? Do they have good range of motion? Are they able to turn? Or are they kind of blocked when they try to rotate? Extension and flexion, because that tells me a lot about the joints. Are the joints in good shape, or are the joints rather arthritic and stiff? Or it could also imply that perhaps the muscles are in spasm as well, which is the reason why people can't rotate very well if they have a lot of spasm. We'll look at the Sperling's test, which is a test where I basically will turn the neck and kind of rotate it towards this side. If I think that somebody has a pinched nerve on the left side, and if I rotate away and kind of tilt it towards the left side, I'm closing down their nerve tunnel, and that's called a Sperling's test. Reflexes, we'll check the upper extremity reflexes. Sometimes they can have some asymmetry in the reflexes. And of course, muscle and sensory testing. Proprioception just means that you know where the extremity is in space or the digit is in space. So if I move their finger up and down, they can tell me that they know if it's up or down. And that can imply that the spinal cord is working normally, or perhaps there's a problem with the spinal cord itself. These are just abnormal reflexes. So, for example, upper extremity reflexes, C5, C6, C7. This would be the biceps, this would be brachioradialis, and that would be triceps. So I can tell if there's a problem with a C5 nerve root because they don't have a biceps reflex, or if they don't have a triceps reflex. Those are the things that we look for in conjunction with motor and sensory findings as well. It doesn't have to be 100% specific, because a lot of folks that I see, their reflexes are diminished anyways, kind of diffusely. And of course, we check the strength as well. So I want to look at all the motor strength in the upper extremity, and then we'll check their sensation. And this is called a dermatome map. And so if you ever have a physician kind of poke you in various areas of the skin, you're thinking, what in the heck is he poking me for? Well, he's poking in various areas that correspond to, for example, the C5 dermatome or the C6 dermatome. So like, for example, sensation that comes down into this area of the hand is known as the C6 dermatome. Or on top would be C7, or on the side would be C8. So if somebody comes in and they have numbness across the ulnar digits of their hand, it could be a C8 problem, or it could be an ulnar nerve problem. So these types of things can help decipher exactly where the problem's coming from. Most of the time you can make the diagnosis without getting an X-ray or an MRI. I can tell what's going on, and the only thing that really helps me do at that point is to actually determine the severity and the location of the actual compression. So we talk about differential diagnosis, cervical disc disease. What kind of things can cause neck pain? I have to really take these things into consideration, because not everybody that comes in is going to have a benign problem. Some people will have some serious issues when they come into the office. They can have tumors. They can have some kind of strange neurologic disease like ALS or Guillain-Barré. Idiopathic brachial neuritis just means that there's an inflammation up here in the brachial plexus. But these are really kind of strange birds. And what I usually tell the residents and medical students is that when you hear hoofbeats, don't think of zebras. So common things happen commonly. You're usually not going to see this walk in the office, but you always want to have that in the back of your mind when you're thinking about it. And then we'll move on to the x-rays. And so then this is a typical x-ray of a patient, looking at them from the side. This is from the front, and then this is what we call the open mouth film, to look straight back through the throat to see the C1, C2 joint. And so when I look at the alignment of the neck, I like to look at the disc spaces, which are the clear spaces between the vertebral bodies. I like to make sure that the anterior body line, for example, you can see the relationship between the vertebral bodies in the front and then the back. It's a nice, smooth, confluent line. There's no step off of one vertebral body forward or backward. There's no collapse of the disc spaces, for example. So we'll note that. We can notice the soft tissue shadows in the front of the neck, if there's some kind of soft tissue fullness that may be a problem. So you can gain a lot of information from that. And then this is an oblique film, so you're looking, take the patient's neck and just kind of turn them a little bit. And then what you do is you look right in their nerve tunnels. See those nice nerve tunnels right in through there? So that's a good view. Additional views that we'll do are called flexion extension films, and I'm looking in this particular instance for instability of the segment, meaning it's moving more than it should be moving. And sometimes on a static film, especially if somebody comes in after a trauma, they may have some muscle spasm, and that spasm can kind of protect them and keep them from having a forward shift one way or the other. this is how you can kind of pick that up by having them flex and extend. And so you can pick up some information in terms of instability. The MRI is really the best study to look at the nerve, to look at the spinal cord, to look at the soft tissues. It doesn't see the bone very well, but it sees the bone marrow. So what you're seeing here is you're seeing the bone marrow of the vertebral bodies. And then you're seeing the disc spaces very nicely in between the vertebral bodies. The bright signal that you see, that's all the spinal fluid. And then you see the spinal cord coming down like so. That's the back right behind the spinal cord. And this is an axial image, so you're looking right down the tube now. So you take the spine, you're kind of looking right down the tube. And here is the vertebral body in the front, nerve tunnels on the sides, and then again your spinal cord, the spinal fluid around it. This is the back of the neck, that's the front. So you can see a lot on the MRI. I utilize the CT for a couple of different reasons. Number one, if somebody can't have an MRI, like if they have a pacemaker in place or some kind of defibrillator, perhaps some kind of aneurysm clip, there's a couple of contraindications to MRIs, such as those types of hardware. For example, total hip is not a contraindication. Total knees, plates and screws, those are okay. It's just the things like the electrodes, which are a problem. But it's very helpful to look at the bone. Now you can see the bone very well. See, all the soft tissue is kind of dark and the resolution is rather grainy and noisy. But the bone shows up very well. So this is what we use for trauma. On our trauma patients, they get a full scan of the spine, cervical, thoracic, and lumbar, because you can see any fracture in that instance. But what you can see here is you can see the bone, you can see the plate and screws. I can tell if this patient is fusing well. For example, that's a bone graft in there, by the way. And I can tell if that patient is fusing through here or not. You can see it in this plane as well. That's looking at it from the front. That's called a coronal reconstruction. This is called a sagittal, meaning that it reconstructs the slices of the CT scan, and then the computer formats it so that you're looking at it from the side like a big X-ray, and you can kind of scan back and forth. That's the axial presentation, so you're looking right down the tube. What about EMG or nerve conduction velocity studies? We'll utilize these for a variety of different reasons. I think it's helpful in individuals if we think perhaps that they have some kind of neuropathic process going on, like a neuropathy is where the nerves in the extremities are having the issue, not so much in the spine, but it's more the smaller branches of the nerves can start to undergo degeneration, in which case they may start to fire intermittently and give patients what we call burning dysesthetic pain. It can actually affect the motor fibers as well. So you can tell if there's a problem like a radiculopathy, which is coming from the neck, or you can tell if there's a peripheral nerve problem like a carpal tunnel syndrome, or an ulnar neuropathy like cubital tunnel syndrome. So it's helpful in that instance, but again, your clinical examination will probably help. But if your clinical examination and your imaging are really rather confusing, then maybe an EMG can kind of help, but it's kind of rare. The thing to know about the EMG is that the changes don't take place for a minimum of 3 weeks until after the symptoms have started up. So what do I do for folks? Most folks that I see that come into my office, I'm not operating on them, and really they don't need surgery. Most people can come in and the body has an amazing capacity to heal and repair itself. So sometimes rest, sometimes some inactivity, a little downtime can be helpful. But I don't really mean bed rest for an extended period of time. Really 24 hours in bed is about as long as you'd want to go for. Because if you spend too much time in bed, it really does make the muscles rather weak, and it creates a longer period of time for rehabilitation for those individuals. So we really dissuade people from inactivity. Sometimes a soft cervical collar can be helpful. Non-steroidal anti-inflammatory medications, if there's no contraindication, like blood thinners, things of that nature. Steroids, like oral prednisone, like a prednisone dose pack can be helpful. Selective nerve root blocks or injections, also utilizing steroids, can be helpful. Physical therapy, traction exercise modalities. Traction can be very helpful for individuals that have a lot of arthritis in their neck. And then manipulation, but I use this, I have this on here just for completeness, but manipulation it can be dangerous in the neck. And if that's going to be done, then the individual doing the manipulation needs to be fairly well versed in how to do it, but also understanding the potential complications, which would include stroke with the manipulation. So who do I operate on? Well, most folks that don't respond to non-operative measures, those are the ones that are probably going to need an operation. The folks that have significant pain that's not getting better. If the pain's mild, they don't need surgery. They'll probably get better with time. But if it's interfering with the quality of their life, if they're depressed, if they're not getting along well, because of that pain, and they probably would do well with an operation. If they have progressive neurologic deficit, like that numb and clumsy syndrome I was talking about, or if they're getting weaker progressively, like the muscle in the biceps is no longer working, or their deltoid's not working, and they're getting progressively weaker, they might need to have something done rather emergently. So, and the other thing is correlative imaging studies. We like to make sure that there's actually something to operate on when we do the operation. So we need to be able to see it on the testing as well. This is pretty much, that's all we have to do for folks. I mean, that's all the procedures that I can do on you. It depends on the individual. It depends on the problem. But there's a number of them. And so we're going to focus today really on the disc replacement, but we're going to talk about fusion because that's the gold standard. And so anterior discectomy and fusion has been around for a long time. It goes back to Dr. Smith and Robinson back in the 50s. And what they described was removing the disc space from the front of the spine. So we'd go in through the front of the neck, either the right side or the left side, take out the disc, and then place a block of bone in between there. Actually, the way it was initially described was they would just take the disc out, let the bone kind of flop down. Well, the problem was if it flopped down, you kind of lost the height. Everything kind of closed down on top of the nerve roots. So it became apparent that something needed to be placed back in there to kind of jack it open. So as the disc space is distracted apart, that creates more space for those nerves to exit out of the nerve tunnels. And so what it does, the fusion, is it stabilizes it. You kind of distract that open so it restores that normal cervical arc, what we call lordosis, which is helpful too for the alignment. It arrests any kind of spur progression because when you fuse it, it's no longer moving anymore. If we talked about the spurs form because of continuing stresses to the bone. So if the bone fuses, that stress is diverted someplace else. So the spurs go away at that point in time. And so you're just basically opening up those nerve tunnels. I've done a lot of these. It's a great procedure. It's the gold standard, as I mentioned, and it works like a charm for people that come in with radiating pain down the arm or pressure on their spinal cord. We tend not to do it for patients who have just what we call axial neck pain because that's a big variable. That's a tough nut to crack in terms of treating people with just pain in the neck with surgery. So we tend not to do that very often, with the exception of perhaps few cases. But if you look at the results of this is a study that was done back in 2005. 71 patients with ACDF, which is anterior cervical discectomy and fusion, allograft, which is cadaver bone, and a plate. When I first started doing these, when I started practice back in 1998, nobody was using plates and very few people were using allografts. Now everybody uses allograft, everybody uses plates because it stabilizes and we don't have to harvest that bone. I don't know if anybody in the room's had their bone harvested here before. It's pretty painful and it can hurt for a long period. It could be lifelong pain actually. 40% of patients lifelong can have pain with autograft harvest. And so when they followed those folks out, they had a good fusion rate, 93% fusion rate, 82% had symptom resolution. Maybe half had a little subsidence, which means it kind of collapses down a little bit. The graft does and kind of resorbs into the patient's own bone. Segmental kyphosis means it's kind of falling over a little bit, which is not a good thing. And then this number right here, adjacent segment disease, means that the level above or below is starting to undergo changes. So if you fuse a level, as I mentioned now, that level that's fused is no longer experiencing the stress. The stress is going to be basically shifted either above or below that disc space. That's known as adjacent segment disease. Transitional syndrome is another way to describe it. And so you saw 73.2% of those folks, when you followed them out 7.2 years, had adjacent segment disease. And actually, the numbers that I quote to my patients are 2/3 by 10 years will have problems. So you know it's about 3% per level per year. It's a real phenomenon. 19.7% reoperation rate, and most of these for adjacent segment disease. What about the complications? I mentioned graft site pain. That's because of the allograft or autograft bone, but most of the time we're not doing that much anymore. These are approach related, so because we're going through the front of the neck, you can have some difficulty with your voice. You can be a little hoarse. Rarely is that permanent, but sometimes it can be. Esophageal injury, meaning perforation of the swallowing tube, is pretty unusual. But most people will have difficulty with swallowing for a short period of time just because of the swelling that takes place in the throat after something like this. Neurologic injury is very rare. Pseudoarthrosis, meaning it doesn't fuse. You can see that usually between 3 and 7%, depending upon how many levels are done. It's higher in smokers. Anybody on nicotine really increases their pseudarthrosis rate, so I encourage people to stop nicotine, tobacco, e-cigarettes, any of those things prior to their operation, because anything with nicotine impairs bone healing. And then infection, which is rather unusual with this type of operation. So, adjacent segment disease, that's kind of bringing me into what we're going to talk about here, which is disc replacement. The idea of adjacent segment disease, when you look at some of these studies, intradiscal pressure is increased in flexion by 73% above and 43% below the fusion, whereas another examiner didn't really demonstrate that. But it's interesting because when you look at something like this, when you have a big fusion like that, that level's going to go or that level's going to go over time. Yes, ma'am?
If I understand, you said you go through the mouth, the front?
We don't go through the mouth, we go through the front of the neck. So when we do the anterior approach to the neck, we make an incision on the front of the neck. And so it's a very simple approach because what it does is you really don't have to cut any muscles. You're kind of going transversely across and hiding the incision in a skin crease. The only muscle there that's actually cut is the platysma muscle, which has no known function. But all the other big muscles and all the vessels and so forth, you just kind of go through them, kind of weave through them, spread them apart, move the esophagus over, and that drops you right on the front of the neck. So adjacent segment disease it can be a real issue. Dr. Hillebrand in '99 talked about 3% per level per year. And that's the number that I usually quote is you have a cervical fusion, you have about a 3% incidence per year. So by 10 years, it could be 30% of having another problem. And that just kind of shows you what would happen if that last patient, so she came back after this big long fusion, and then I had to fuse the next level up. So they kind of run out of levels eventually, but it stiffens the neck up, creates more problems to the level above and below. So what about cervical disc arthroplasty? Why would we do something like that? Well, the idea is what can we do to minimize that risk of adjacent segment disease? And that's where this arthroplasty comes from. We do it in the shoulders, hips, the knees, preserves the range of motion, keeps patients fluid, keeps them moving. So the idea would be the same thing in the neck or the lumbar spine. Perhaps we can minimize that chance for adjacent segment disease. Maintain your normal neck mobility. It's stable. You're jacking open the disc space, so you're getting the pressure off the nerve root. You're taking out the disc, getting the pressure off the spinal cord, just like you would with an anterior cervical fusion. Only the difference is, before I put that graft in, I'm going to put a disc replacement in. So it's the same operation, right down to the point where you actually put something in disc space. Yes, ma'am?
What's the disc made from?
Well, I'll show you. I'll show you what the discs are made from. What are the problems with these? Well, is complicated insertion? Maybe it is. First time I did it, it was tough. It was different. It was just a different procedure. And it's like I say, it's the same operation until you get down to when you actually have to put the prosthesis in. So you have to be a little bit more vigilant in terms of when you place the prosthesis about certain things like the amount of decompression or the ability to see. I have to be able to see this on x-ray so I can get it in the exact location that I want to do it. So there's some of these intraoperative things that I can show you that what I'm talking about. Wider decompression, so I have to really work my way out into the nerve tunnels from the front, because if I'm doing a fusion and I jack open the disc space and I put a block of bone in there, if there's still a little spur maybe hanging on by the nerve root, it doesn't really matter because there's no motion there anymore. So that spur is not going to touch that nerve root. Whereas if you have continued motion there, that spur is going to bang that nerve root every time you're flexing and extending your head. So we have to make sure that we get that spur out, and that requires a wider decompression. Spontaneous fusion, that does happen. It's a little bit more rare. We try to prevent that. That means it fuses across the front of the disc space, and there's a variety of reasons for that. If it fuses, it kind of negates the purpose of doing the disc replacement to begin with, so we try to avoid that. Implant life is probably not an issue. Most of the explant studies done in cadavers, they've cycled these things till you'd be 1,000 years old before they fail. So really for normal individuals, they're probably not going to fail unless they became infected or something like that, or they had some kind of trauma. They really shouldn't. Wear debris, same kind of thing as you see in the knees and the hips, where you got all this motion going on. It kind of stirs up a little bit of particulate debris. Eventually that debris kind of extends out into the zone. Sometimes it gets in the bloodstream. But like I say, it's been studied in knees and hips, and it really hasn't been a problem. Cost and MRI compatibility are also things that we would talk about. These are just a few on the marketplace. These are probably the ones that are being most widely utilized. And so what are they made of? Well, most of these are going to be very similar to like a knee replacement, where you have a metal end plate on the top, which would, for example, the knee would be the femur, on the bottom would be the tibia, and in between you have this polyethylene center, which is the plastic spacer. In the spine, it's very similar. It's very analogous to a knee. So you have this basically end plate, which is the metal end plate on the bottom, so it's going to fit right in between the vertebral bodies, right in that disc space, so one's going to articulate on one side, and the other's going to basically fit on the other side. And in between, you have this polyethylene, which is plastic. That's the cushion now. So that's going to allow for the toggling of the metal on one side and the other, so the patient can continue to flex and extend and kind of rotate. And that's what it looks like on the x-ray. So you see the metal, but what you don't see is you don't see the poly in between. That's just a dark space because it's radiolucent, so you don't see what it looks like. This was the first one that was out. This is the first one I put in back in 2007. And this is Prestige. It's a metal-on-metal implant. And the way that this actually articulated is it looked like a cervical plate from the front. So you can see you would put this in the middle, in the disc space, and then they would screw that right into the vertebral body's top and bottom, just like we do a cervical plate for a fusion. The thing about it works fine. It works great long-term studies. The problem is it's a little bulky in the front. That plate's a little thick, and it has a little bit higher profile. Sometimes it can impair swallowing. Those sorts of things can be an issue. ProDisc C, which is C stands for cervical, obviously, is another metal on poly. So you've got the poly in the middle. This one is different because it has a little keel that goes in the middle. So the keel goes right down the middle of the vertebral bodies, kind of stabilizes. You can see what it looks like here in the front. This is the frontal plane right here. Most of these have some kind of grit-blasted surface on the top or some kind of porous coating that allows for the bone to grow into it. So that's why you see this, rather than some kind of smooth, nice, real polished metal, you don't want that. That's too slippery. You want something nice and porous that's going to fit in that bone. It's going to be real kind of sandy and gritty, and then the bone will kind of grow into that over time, which kind of adds that stability, enhances the durability and the longevity of that prosthesis over time. The Mobi C, that's another one. So you see the common theme is really metal on poly, metal on top, metal on bottom. This one's got some teeth on the sides. So the teeth kind of grab the bone, keep it from extruding out, because that can be a complication, or at least it was thought to be a complication of disc replacements, was this thing would suddenly come spitting out of the neck. You know, you extend it, it's going to come flying out. I can tell you that of all the disc replacements I've done, and I've done a bunch, once you start to put that thing into the disc space, it is murder to get that thing out. You just can't back it out. It's almost impossible. So just by putting the teeth in or putting any kind of coating on it, and the pressure and the surface area of the bone that actually attaches to that or even just touches it makes it very hard to pull out. So it's very rare to see any kind of subsidence. And the only reason you would actually see extrusion of the implant is if it was improperly positioned to begin with. So it didn't quite get in there, and they were trying to bang it in, and they couldn't get it down to where it needed to be. And perhaps over time, that thing started to kind of loosen up a little bit because it wasn't quite in the proper location. And I'll show you what I mean, because we talk about the center of rotation in the spine. It's very relevant when you talk about putting in a disc replacement. Yes, sir?
How do you determine which one of those devices you're going to use?
Well, it's a good question. When I first started doing the first one, it was the one that was available. And then I liked the fact that the ProDisc had some good numbers on it. The ProDisc is it's a metal on poly. I moved away from the metal on metal because I didn't like the high profile. And then what you're going to look at is you're going to look at what disc replacements have indications maybe for single level or even multiple level. So there's a disc replacement now that has what we call an FDA indication for more than one level. Most of these disc replacements were only looked at for one level for the FDA studies. So when we do procedures, especially in spine, a lot of this is what we call off-label procedures, meaning that it was never studied or submitted to the FDA for this specific use. Bone screws, for example, like pedicle screws. It was submitted to the FDA for what we call spondylolisthesis, which is a forward shift of one vertebra. Now pedicle screws are pretty much the standard of care in any spine operation. Most spine surgeons are doing them for pretty much any kind of fusion. But when they do that, unless the patient has a fracture or a spondylolisthesis, it's called off-label. Now, in the cervical disc replacement arena, if I try to do something off-label, the insurance company says, you're not going to do it. They won't cover it. They won't pay for it. So I can't get my patients approved for procedures unless they have, the perfect indications. And I think for disc replacement, they're kind of catching up, but they've been very slow to the party because the disc replacements have been around now for 6-7 years. And a lot of these insurance companies are finally saying, okay, yeah, you can go ahead and do them. So that has some of it to do too. Some of it just has to do with ease of insertion.
Question?
Yes.
What kind of metal is it?
What kind of metal is it? It's a titanium metal. Some of them are what they call tantalum. It comes from various manufacturers. Suffice it to say, it's an alloy. Some of it's kind of, comes from different companies, so it's proprietary. But most of it is an alloy of some kind of titanium, typically. They're not stainless. The Prestige was stainless, that metal-on-metal one, but all the other ones are not. So this is just an example of a patient that I would treat, and a 47-year-old lady would come in with arm pain, and recalcitrant arm pain, hasn't responded to really a variety of non-operative measures plus time, and most people really will get better within about 6 to 8 weeks from the onset of their symptoms. But in these instances, when I show you cases, obviously they have not gotten better. And so you can try various things, like I say, non-steroidals, physical therapy, time. Sometimes even cervical epidural injections, I think, can be helpful. But she did not, and she has this radiculopathy, and when you look at the disc space, she's got this little beak kind of projecting off the vertebral body down there, which is consistent with the bone spur. Good overall alignment. When you look at her neck, you can see on the MRI, here's the spinal cord coming down, and she has some narrowing now, right where she had that bone spur off the front, but now she's got, when you can see this here, she's got bone spurs off the back of the spine as well. And so that projects into the canal, and when you look at the spinal cord, you can see that left neuroforamina is pretty well gone, and the right side's fairly compromised as well. So we did the metal-on-metal prosthesis, and you can see how it opened up that disc space, kind of cranked it open. And that's what it would look like sitting in the patient. That's what it looks like from the front. It looks like a plate sitting right on the front of the spine. From the side, you can see the plate, but you also see that extending backwards. When you look at the disc replacement, we talk about it needs to simulate normal range of motion, and that refers to degrees of freedom. So flexion, extension. You think about what your neck can do. You can tilt your neck side to side. You can flex and extend. You can rotate it. You can rotate and tilt at the same time. That's a lot of motion. There's a lot of, when you think about that, what the disc actually endures and what the facet joints endure on a regular basis is pretty incredible. And so anything you stick in there has to be able to do that too. And that's a lot of stress because your head's about 10 pounds. And when you're moving your head around all day long, back and forth, that's a big fulcrum down here. And that puts a lot of stress on that disc replacement or the fusion. And so we talked a little bit about center of rotation. And that's what I was alluding to earlier, is that your center of rotation in the neck is slightly posterior to the midline. And so when the designers come up with an idea in terms of how to make a disc replacement, you have to somehow or another simulate that center of rotation. Because if you put the thing too far forward, too far sideways, it's going to have too much stress on it, and eventually it's going to fail, just like anything else. If you don't have that thing in the right spot, where it's under the most minimal amount of stress, eventually it's going to fail. And so that's where you see your failures with these, is really improper placement of the disc replacement. And so some of these are ball and socket, some of these are not, but they have to be able to resist shearing. That's the other part of it, back and forth. So there's a lot of forces that these disc replacements have to be able to endure and resist, and that goes into the design as well. So again, range of motion with this one, for example, this ProDisc C, you can see it back and forth, lateral bending, flexion, extension, normal 7.1. The ProDisc gives you a little bit more, 20 degrees, but it's not going. You're not going to bend 20 degrees just because you have disc replacement. Your joints and your ligaments and so forth will keep you from doing that. And then axial rotation, which means side by side or side to side. And so this is another case report, 48-year-old with left arm pain. And again, a very similar x-ray, a little bit less osteophyte here. You see the loss of the disc space height. She's got a little bit bigger disc herniation here. You can see that pressure on the spinal cord now. See that? Cord's really kind of compressed in the midline. And then when you look at it here, that's the disc right there, that dark structure. See that? This is the cord, and the nerve root's supposed to come out like that. You can see what it looks like over here on the right side. That's pretty normal. But on the left side, it doesn't look so hot. And so she actually received a ProDisc C, because that's when I moved away from doing the other one and started doing the ProDisc. And so the keel cut, that's like a little keel right in the middle. That helps stability. It helps increase the surface area of the actual end plate, makes it more stable in the bone. And then, of course, you've got the polyethylene in the middle, and that allows for the rotation. So it's very stable prosthesis. How do we know these things are safe? Well, you have to test them. And what I was talking about earlier with respect to the FDA, they call these the IDE studies, Independent Device Exemption Studies. So any device that's, if I came up with an idea today, I'm going to have this great idea, I'm going to invent some new cervical disc replacement that's going to be the greatest thing. Well, I have to design it, then I have to test it, and then I have to study it in individuals, and I have to submit that to the FDA for approval. And you have to compare that to something that's considered to be the gold standard. And most of the time when you do that, you do what's called a non-inferiority test, which means that I'm trying to prove that this is no worse than anterior cervical discectomy and fusion. And so there's a lot of rigorous types of things that go into the FDA studies, and those are called the IDE. But when you look at what this ProDisc C showed, they compared it, of course, to the cervical fusion. So you had even number of patients, cervical fusion. Of course, they were all single levels, and they were all randomized, and they had to follow them up. Inclusion criteria basically are just people between the ages of 18 and 60 years of age that had symptoms that didn't improve. But what they couldn't have were any of these. I mean, that's a big exclusion criteria. There's a lot of stuff right there if you read that. I mean, things like more than one vertebral level, any kind of instability, previous fusion, radiographic confirmation of facet disease, known allergy to cobalt, chromium, molybdenum, titanium, poly. I mean, all these different things. These are real contraindications to doing a disc replacement. Those things were considered during the IDE study. And so when I'm evaluating a patient, I'm going to make sure that they don't have any of these things going on. Like osteoporosis, for example. Osteoporosis is a contraindication to doing a disc replacement, because if you put that metal prosthesis into soft bone, crunch, and then your bone basically will compress. And now if you lose that height and that disc replacement is now sunk into the bone, it's going to be very unstable and kind of move around. That can lead to neurologic problems.
What would you do if a person had osteoporosis and advanced degenerative changes, the loss of inner disc space that arthritis change?
Right. So,
What would you do then?
so the question would be, if you had a patient that has osteoporosis, but of course all these other degenerative changes that we've been talking about, well, then you probably wouldn't do a disc replacement. You would probably do a cervical fusion. And it depends upon what the symptoms are. If it's arm pain versus if it's pain, or versus if it's spinal cord compression, then you would do something different. Sometimes I'll do procedures from the back of the neck as well if it's multiple levels, and we'll just do what's called a laminectomy. But in the setting of osteoporosis, you have to be very careful about any kind of implants that are placed, just because they can pull. It's like trying to hang a picture up by putting a nail into the drywall without hanging it on the stud. Eventually it's going to pull that right out of the drywall, and the same thing can happen in your spine. You put a lot of stress on these implants, it can pull those implants right out of your spine. It can be a problem. Osteopenia is different from osteoporosis. That's more of a radiographic diagnosis. And if there was concern about it, then obviously the individual would probably undergo a bone density study to determine what their true risk is, what their categorization would be, if they're osteopenic or osteoporotic. So in this study here, they were looking at the range of motion again. No problems in the ACDF, no problems in terms of migration or anything like that. But when you compare these two patients, these two groups of patients side by side, they looked at range of motion, they looked at the neck disability index, which basically is pain. They looked at return to function. And what you can see, here's the ACDF group right here, and that's the ProDisc C. Flexion, extension, range of motion. So you saw that the disc replacement stayed up and never fell down. It's pretty much the same. Whereas the fusion group, right after they had it, boom, they dropped down, they got a little bit stiffer. So they did lose a little range of motion across that segment. Now, functionally speaking, it doesn't make any difference if they lost range of motion because those patients don't notice that anyways. And when they ask me that, will I lose range of motion? I say, yes, but you're not going to notice it, meaning it's not functional. But the only time people can tell that they've lost a little range of motion is if they're driving a car and they're trying to back out and they're trying to look back and they're trying to turn. Most of those folks have already lost range of motion because of the painful syndrome that they already have. So it's probably no different than their preoperative scenario. But when you study this and you compare it, there's definite change in range of motion. And so these folks had good flexion extension. When you look at the visual analog scale pain scores were roughly similar. And ACDF versus ProDisc, neck pain as well as arm pain, both procedures work very well. That goes to what I was talking about earlier about the non-inferiority of this procedure to the ACDF, meaning it works as well, if not better. And then patient satisfaction, a little bit higher in the ProDisc C. How do we do it? Well, I basically will take the patient, we'll lay them down in the supine position, and it's under a general anesthetic. And so what we do is with x-ray guidance, this is a fluoroscope, we're going to basically look at the patient's neck. So I come in from the front of the neck, as I mentioned, and it's just really a nice dissection right down to the front of the spine. Very simple dissection. Patients tolerate it well. They just get a little bit of swelling in their throat afterwards. And so you can see this is the front, and that's kind of the plane that we're getting down to. Here's the spine right here, and we're getting down into that area. And so once I get down into the disc space, as I mentioned, I distract it. I put these little posts into the disc space, kind of crank it open, and then I just remove the disc material, scrape out the disc, and then I work all the way back. Here's the spinal canal back here. I take off those little bony osteophytes off the back of the vertebral bodies that are always present, causing pressure on the nerve roots and the spinal cord. Take those out, and I try to make that flat, make that end plate as flat as I can. Normally there's a little concavity to it, so I try to flatten that end plate off, and that way it accepts the disc replacement a little bit better. And then when we get ready, there's going to be some kind of trial, depending upon the system that we use. But you're going to trial it basically, so there's going to be different sizes, and I'll put those trials into the disc space and make sure that it fits well into that patient. Every patient's different. Big patients, small patients are all going to have different size vertebral bodies, and you want to basically fit something that's going to be custom designed for that individual. It's not really a one-size-fits-all kind of thing. And so once you trial it, and then we basically implant the implant. But this is what I mean. So you've got the trials that kind of mirror what the actual implant looks like, different height, different coronal widths. So that some are wider, some are more narrow, some are taller, and that's pretty much how you do it. So that's the implant insertion, and then finally it goes in, and that's what it looks like. This specific one, so it fits right in the middle. So results, Delamarter and Ziegler were the ones I learned the ProDisc from. They just recently put up a 5-year study, and the 5-year results are really good. 97.1% no secondary surgery in the disc replacement versus 85.5% infusion. What that means is that only 3% of those disc replacement patients had to have a second operation in that 5-year time period versus 15% in the fusion. And so most of those procedures that are done in the fusion are either for adjacent segment disease or some kind of problem like it didn't heal, okay? Whereas you're not seeing that with the cervical disc replacement patients. And then a meta-analysis, which is basically a study where they basically pull all of the literature that pertains to a specific subject matter. So these researchers, Dr. Yin, went in and pulled all of the data that they could find on cervical disc replacement, and he found 10 papers with long follow-up. And basically they found arthroplasty showed better mean neck disability indexes, reduced operation related to the incident procedure, meaning they didn't have to do revision procedures on the disc replacement, like I mentioned with the fusion, where they had to come back and revise it because it moved or it didn't fuse solid, something along those lines. So you're seeing a lower complication rate and a lower reoperation rate specifically for that. Interestingly, he didn't find any difference in reoperation for adjacent segment disease. I've seen some studies that have said that. I've seen some studies that have suggested that there is a much higher incidence of adjacent segment disease in the individuals with fusion. So the question hasn't been answered yet. And we'll probably have the answer maybe in another 5 years. That time we'll have some 10-year outcome data. But right now, we don't know for sure that adjacent segment disease is diminished in patients with arthroplasties either in the neck or the lumbar spine. Yes, sir.
You could only put one in the neck then, is that what you mean there?
Well, right now, again, the FDA study was for single level. So when you go to an insurance company, you say, I want to do 2 levels. And they'll say, can't do it. It's experimental. It's not approved.
It's church.
With the exception of one now, which is Mobi-C. And Mobi-C has a study where they did it in 2 levels. So you can get a 2-level now approved for Mobi-C. I've done 2-level disc replacements. It happens to be on work comp patients because they're the only ones that would pay for it. But, it's a great procedure. But it just, like I said, the insurance companies have to catch up. And we're seeing now 5-year data, multi-level cervical disc replacement patients. Actually, I've seen a couple studies where they've done better, pain-wise as well as reoperation-wise.
I mean, could you put all in or not?
Oh, I could do 3 levels. Easy.
3 levels would be the max that you could put in your neck?
Yeah, and the reason for that is, I'm not even really doing more than 3-level neck fusions.
I mean,
at
I
most.
just didn't know whether
Yeah.
it would be feasible to
Oh,
put
yeah,
it together.
you could do it.
You could do it.
It could be done. Yeah. I've seen some pictures from Europe where
I've
every
heard
disc
they do it a
space,
lot. Yeah.
every disc space was filled by a disc replacement now. That's just not good medicine, but it's an interesting picture. So basically, the post-op care for these individuals, overnight stay in the hospital, you could go home the same day, but I keep them overnight in the hospital just because the hospitals are reimbursed better if the patient stays overnight. If the patient goes home the same day, the hospital doesn't get reimbursed for that implant. The hospital loses the cost. And it's just not fair to the hospital. So I put individuals in overnight in the hospital. We put them on nonsteroidals for 1 week, and that goes to the fact about the risk for fusion with the disc replacement. So I'm trying to prevent fusion, so I put them on nonsteroidals. Whereas my fusion patients, I tell them not to take nonsteroidals because nonsteroidals actually inhibit bone formation. So I want them to not have bone formation for a disc replacement. There's no bracing. We get them moving right away. Return to work ad lib. My personal experience is that they get back to work quicker than fusion patients, and they probably have less postoperative pain than fusion patients do as well. And we're seeing some numbers, some studies that support that as well. So a lot of information, and hopefully it was clear. Yes, ma'am.
You touched on neurological diseases. For instance, Parkinson's, they are not as stable. And you mentioned something about stability. If they're unstable, you'd rather do fusion than a replacement. Is that true in Parkinson's?
Well, Parkinson's patients are just unstable on their feet. It's not really a spinal stability issue with them. So I was speaking more to the point of spinal instability. Yeah, so if there's an instability in that spinal segment because of previous trauma or severe degenerative disc disease, you wouldn't do it in that setting. Yeah. Yes, ma'am.
Like when you're sleeping on your side and you wake up and your arm is asleep, hands are asleep, the first 3, is that, would that be like a spur that's causing that or just joints?
It could be certainly a spur. Typically, if you're waking up and your hands are numb, it could be carpal tunnel syndrome as well. There's a variety of causes for it, but
I had carpal tunnel down on this. These 3 fingers are numb.
yeah. Yeah, and the numbness it's interesting that you mentioned that. She's talking about numbness in fingers. What I tell folks is that when I'm operating for pain because I can't make your numbness better. I can't guarantee that I could make your numbness better if I did an operation on your neck. So somebody comes in with a big disc herniation and they have what we call radiculopathy. I tell them, your pain's going to go away. But if you have muscle weakness and you have a lot of sensory deficit in that dermatome, I can't guarantee that. Now, you'll continue to have recovery for probably a year following the operation, but you may not get all that function back. And that's really just kind of goes to the fact that there's already been previous nerve damage done by whatever the etiology was that were causing the symptoms. So there's some things that don't necessarily change. But again, I'm operating primarily for pain because that's the most predictable in terms of relief. Numbness or weakness is not very predictable. Yes, ma'am.
What about, you hear so much about laser treatment now for
Yeah.
Is that an option anymore? I mean,
So the question is laser treatment for spinal disorders. And you're right, you do see a lot. There's a lot of advertisement on TV. I've seen it myself, which is basically what we use lasers for in spinal surgery is for example, coagulating or trying to basically make a tumor kind of go away. You're trying to basically destroy a tumor. That's where the inception was for lasers in spinal surgery. Lasers basically heat, and that's how they cut. So if you basically introduce a laser beam into the spine, the problem with doing a laser beam into the spine around the bone is that bone is basically a mineral. It's calcium hydroxyapatite. And so if you go in and you shoot this laser beam off of a piece of metal, what's going to happen to, or I'm sorry, mineral, what's going to happen to it? It's going to basically refract or reflect. It's going to go one direction, go the other direction. And it's dangerous in the area of the spinal canal because that's where the nerve roots are. So when you see the stuff on TV, what they're using the laser for is one of two things. Either to denervate the facet joints, which are the joints on the backside of the spine, and so they're kind of cooking those little sensory nerve endings to the facet joints for back pain. The other thing that you can use it for is for kind of heating up the disc space and doing what's called a nucleoplasty on the inside of the disc space. And that's a little bit, it's the literature on nucleoplasty is not very good, to say the least. So the laser is done for those two things in addition to tumor surgery. Most of the time when they're decompressing your back, they're just going to basically remove the bone with a little bit of burr and what's called a kerrison rongeur. And so that's typically how those laser operations are run. Yes, sir.
Tonight's discussion was mostly about cervical disc replacement and fusion. Is the technological discussion, aside from the details of the surgical procedure, is the technological discussion applicable to the lumbar disc replacement as well?
It is. Yeah, the lumbar disc replacement actually was the first one out. And the first lumbar disc I did was back in 2004. There's some things about lumbar disc surgery. It's harder to get there because you have to go through the belly. You know, you've got the internal organs in the way. There can be some complications with bleeding, with other things associated with going through the abdomen. You're probably going to have a difficult time doing multiple levels because you've got the aorta and the iliacs in the way and so forth. So you have to typically, I would do this operation with a general surgeon so that they could mobilize the vessels and kind of move them out of the way, and that way I could do my disc replacement. So there's no doubt that lumbar disc replacements have been around for a while, and they're very similar to this. Same
devices.
Yeah, exactly. Yes, sir.
Doctor, which type of surgery do you do more of, the artificial disc or the fusion?
I do more fusion surgery than I do artificial disc surgery for a variety of reasons. A lot of it comes down to what we were describing earlier with just getting multiple levels approved through the individual's insurance companies. A lot of folks I see, I do two or three levels anyways because they have multiple levels with pathology. The ones that I see where they walk in with just a single level, I'm usually pretty big on doing a disc replacement unless there's some kind of contraindication. But so just by the sheer numbers of people that I see, I'm doing a lot more fusions.
So do you think if the insurance companies would support it more, that you might do more of the artificial?
Oh, absolutely. Yeah, there's no question about it. I think that my personal impression is that in the right patient, I think a disc replacement is probably a better procedure than a fusion. I don't want to dissuade people from, I don't want to do a fusion because Dr. VanFleet says that arthroplasties are better. I'm not saying that. I'm saying that in certain individuals, if it were me, if I had a C5-6 disc herniation, I'd say, I'd rather have a disc replacement than a fusion. Now, if they said to me, you can't have a disc replacement, you've got to have a fusion, I'd say, all right, fine, I'll do the fusion. Because it's going to work just great. It's going to work perfect. And if my arm is killing me, I'm going to say, I just want you to fix it. If you can fix it with the best thing possible, then do it. But if you can fix it, I'd be happy if you fixed it for me. So that's kind of the way I approach it. You know, I think that the disc replacements are great procedures, but they're really, they're not for everybody. And most folks that I see, like I say, they really for a variety of reasons. Either the disc space is collapsed or they've got spinal cord compression, that sort of thing. So. Yes, sir.
All I noticed on there said that it excluded insulin-dependent diabetics. All insulin?
Just on that study. That's not really a contraindication, no. Yeah. Yeah. No, that was just for that study. All right. Wait, one more? Okay.
Did you, I may have misunderstood this, if you get the artificial disc, would that prohibit or preclude the using an MRI in the future?
No. No. You can still have an MRI. Sometimes you can't see real well at the level of the operation. So, for example, if they continue to have pain and I wanted to look right at C5, 6, and that was the level it was done, sometimes there might be a little artifact, in which case you would do a myelogram and CT study. But it's not a true contraindication.
Besides not
Yes.
smoking and those other things, anything else you can do to help preserve this that you have?
Keep your core in good condition, exercise, have a good diet, keep the weight down.
You know, calcium?
Calcium is important, but it really doesn't have an effect in terms of generating osteophytes or keeping your disc spaces healthy. Calcium is important for your bone quality, but the disc spaces are a little bit different. It's a separate issue. One more. Yes.
Glucosamines and what, are you a fan of any of that stuff?
I'm not aware of any studies for glucosamine in the spine that have shown it to be beneficial. Well, thank you very much for coming out tonight. Appreciate your attention.